anesthesia coding.
Oh, right. Anesthesia. I like doing the anesthesia coding. Uh, Maybe it's because it's like E&M, but it's smaller. It has its own little area in the CPT book, and once you know the basics, you're good to go. You don't. There's really not that many anesthesia codes when you compare it to the volume of the CPT. The first thing you need to know, there's three things you basically need to know when you're doing, again, basic anesthesia coding. You need to know type, the BTM, and find the code. So let's click on the answer here and let's look at the paper that I worked up. Oh, that's very tiny. Oh, there we go. All right. The first thing you want to know, what type of anesthesia are you dealing with? So these are the types that you work with. There's endotracheal, epidural, spinal, general, regional, local, and then patient-controlled. But really, patient-controlled is a little bit different because that's when they give you that morphine pump. If you've ever had to have that, and the patient literally, it's set up that it can't be given closer than any 30 minutes, and the patient can give them the morphine when they want it so the nurse doesn't have to keep coming in. Endotracheal is whenever they put a tube down someone's throat into the trachea, and that's for any type of procedure where they seizure on the brain, any type of procedure that they do where they, when people say, well, they put me under, or you're having, major surgery, then that's the type that they're going to do. That's the also you'll have a separate report, an anesthesia report, as well as an op report, and you don't want to get those confused. When you code an op report, you're coding for what the doctor does, the procedure that he did to you, and it will say maybe on there, the type of anesthesia that was given. But when you look at your bill, you'll also see that the anesthesiologist bills you as well. He's a physician, and he is going to get paid for his services, and he writes a separate report. Let's see, epidural, a lot of women are familiar with epidurals, and that's what you hear in the movies when the women are pregnant and they scream, I want my epidural. And that's what it does. It blocks everything from the waist down. And the anesthesiologist, or a CRNA, which is a certified nurse anesthetist, they come in and they give you that epidural block. Pretty common now. An op report is done for, it's not an op report, there is a report given for that as well. Spinal, a little bit different than an epidural. General, this is what some people get confused about. A general is not the same as when you go in to have like a hip replacement. They're going to give you the endotracheal anesthesia, but a general is maybe when you're going in for a colonoscopy, or you're going into a procedure where they're not really putting you to sleep per se, they're putting you in a sedated state, and then you come out of that pretty quickly, and then you get to go home, and it's not, when they put you under for a procedure with endotracheal, they have to observe you for a lot longer than they do if they give you a general. Now, regional blocks, this is where you've got a laceration, say, on your hand, and when they do that, they just give you like 5 injections of the xylocaine, and they stitch you up. That general circle or a wall of anesthetic that numbs that area. But they can also do a block that way. If you are, say, you've got a large laceration that's going to be a complicated repair, complex repair on the arm, and you can only have like 8 cc's of xylocaine or lidocaine or whatever they're giving you before it can be toxic to the heart, because it is numbing you. So what they'll do is they'll say, well, I'm just going to give them a block, and they start at the elbow and they inject it, and it blocks the pain from anything from the elbow down. So they can do just like a wheel around where the wound is, or they can block it completely. At like a joint is kind of where they do that. Topical, this is what you're familiar with. If you go to the if you go off to the pharmacy and you just get a topical analgesic that will just numb the skin. You know, when you put babies are teething and you put that gel,
Hmm.
that's classified as a topical. There's some topical stuff that you can get from the ER for burns and stuff. I think Silvadene cream is, you know, considered topical, or it gets into the tissues. All right, let's scroll down just a little bit on this page. The next thing we're going to look at is the BTM. There's a formula that's used with anesthesia, and this is how they get reimbursed. It's divided up on base units, time units, and modifying units. To get the base units, what they do is they've taken every anesthesia code, and most of those codes, you don't start with it as 00. They're at the beginning of your code book. And for each one procedure, they're given a value. And I can't remember, it's like 1 to 20 maybe, I guess. I don't know if I've ever seen one more than 18. But here are what, 5 codes that I just pulled off this cms.gov website. And it just so happened that 00635 has a base unit of 4. That's for a lumbar puncture. Okay, so pretty, you know, it's relatively simple procedure for somebody to do a lumbar puncture. They're just, you know, sticking a needle in your back. Okay, so then you go to 00670. That is the code for spine, open surgery on the spine. Now, say they're going to go in and put plates or rods on your spine because you have scoliosis or something like that. That's the code for that. That's a much more detailed procedure. So it gets a 13 when you're adding up the base units. And it would be the equivalent to having like open heart surgery or your tonsils taken out. Well, open heart surgery is going to have a higher base unit value than having your tonsils taken out, or you will run into situations like, hey, you have an appendectomy and a cholecystectomy. Well, if they take your gallbladder out and your appendix out at the same time, they probably have it's just about the same type of a procedure, same area. The base value is going to be the same. You know, so it doesn't matter which one you list first. So let's go down. The next thing you need to know is the time units. This is real important, and I can guarantee you there are test questions on the time for anesthesia. Be prepared. I can't remember. I think there's maybe 8 anesthesia questions on the CPC exam, and one of them will most likely be on coming up with the time, how to measure time for the anesthesia. What you need to know there is that time starts for the anesthesiologist from the point he walks into your room and starts discussing your procedure with you. He starts the clock then. Now, when you're reading the op report, it's going to say, you know, procedure for the cholecystectomy started at 9:15 and was completed at 10 o'clock. But the anesthesiologist report is going to say that he met with the patient at 9 o'clock and reviewed allergies, you know, asked questions like, have you ever had anesthesia before? All that stuff that he goes over with you before. And then he released the patient to the recovery room nurse at 9:15. So his time goes from 9 o'clock to, 10:15, whereas the op only went from 9:15 to 10 o'clock. So they're going to ask you how much time was involved. For anesthesia, it's a longer window of time. It's from the time he walked in and started talking to you to the time he released you to the recovery room nurse. If there's complications after surgery, it's for the anesthesia. Maybe they have trouble waking you up or something like that. The physician's gone. It's all the anesthesiologist now. So, you know, he could ultimately spend more time with you, and he does spend more time with you than the op for the doctor. So keep that in mind. That will be a test question. I'm sure of it. And scroll down just a little bit more. I think there's one more thing. Modifying units. This is something else you're going to see on the CPC exam because it's just easy to write test questions and throw these in to make sure you understand what the modifying units are. These are add-on codes. And remember, add-on codes cannot be used as first listed code. So when you're looking at your CPT manual and you see that plus sign, no, that cannot be a first listed diagnosis. If you see that on your choices, A, B, C, and D, and one says 991 99100 and then it has the anesthesia code, just cross it off. It's automatically, it's not, because it's an add-on code. It can't be first. Okay, what they're doing is they're saying to the payer, and statistic-wise as well, if a anesthesia is a little more complicated if the patient is under 1 year old or over 70. So if you get an op and that person is 80 years old and they're doing anesthesia, you're going to amend this 99100 at the end as an add-on code. And they'll put those ages in there. When you are reading it and you're doing anesthesia, you see an age listed, that's a red flag. This may have a modifier. The second one is 99116, complicated by utilization of total body hypothermia. Now, you think, why would a person be hypothermic having surgery? Well, they actually induce this state. It's not like a person fell in a cold lake and, you hear they were hypothermic and so that's why they were able to recover because they were underwater 5 minutes, blah, blah, blah. That's not what they're talking about. What they're doing is, like, if they do open heart surgery on a person, they want to slow the heart down, and they're going to put your body in a hypothermic state so that you don't have any ischemic damage because of the open heart surgery. So they will amend this code to the anesthesia 99116, because if you put you in a hypothermic state, it's more complicated to do the anesthesia. He has to take more care with that. The same thing with 99135. This is a complication of utilization of controlled hypotension. Now, you think, why would you make somebody's heart slow down? Well, it's because they're wanting to not have so much bleeding. And one of the examples that I had read about was a hip replacement. If you've ever seen a procedure with a hip replacement, I mean, it's brutal. That not only do they slice you open with a very large incision, but they're like picking you up and twisting you and pounding with hammers. I mean, it's brutal. So you think, you're flayed open like that. That's a lot of blood loss potential. So what they do is they give you hypotension. They slow the heart down, less blood to deal with. They get their job done, and you don't, control your bleeding. So again, when you slow the heart down, that makes anesthesia a lot harder. The last one, complicated by emergency conditions, this 99140. Think about this. When the anesthesiologist comes in and talks to you because you're going to have a procedure done, and he says, Susie, are you allergic to anything? You say no. Or have you ever had anesthesia before? No. Do you have asthma? All these questions that he asks you that he wants forewarning of, so that he can give you anesthesia and keep you safe more or less while he's not having any no surprises while you're under anesthetic. Well, let's say you have a car wreck and you've got, cardiac tamponade, and they rush you into the OR and you're unconscious, and the anesthesiologist is in there and going to start anesthesia. Well, he doesn't know if you've ever had anesthesia before, and if you're allergic to anesthesia, he's got to handle that on the fly. Or say you had throat surgery and it's really hard to actually get the tube down into your throat. Little things like that he doesn't have warning for, and it's going to make his job more complicated. Then you're going to amend that 99140, and that explains to the insurance company why maybe the whole procedure took longer than it should have normally. So it's statistical purposes, and also actually the anesthesiologist gets paid more money. So let's see, when coding for anesthesia, the last thing you need to know for the basic explanation on coding anesthesia is how to look up the codes. And it's pretty simple. That's another reason I like anesthesia. Is, let's say you've got a tendon repair. So what you need to know is you look up under anesthesia, and where is the repair being done? Knee. And that gives you the code. So it's done by anatomic site and then the procedure. So you're going to septoplasty. It's anesthesia of the nose. Arthroplasty, anesthesia, arthroplasty, knee. Then this last one is just the procedure, C-section or cesarean section, and then you look up anesthesia, cesarean delivery. So once you've looked up a few anesthesia codes, it's pretty easy as long as you know your anatomy, and you have to trust the index, because if you look up anesthesia of the nose and you don't know that's where a septoplasty is done, and you go in and you don't see septoplasty listed under 00160, you have to trust that your index is right and that that is of the nose. So that's about it. There's a lot more to anesthesia, but this is the basics. This will get you started.
Get more CPC exam tips, coding certification training, and CEU credits. Go to www.codingcertification.org.